And thank you for those of you that are here this morning. I appreciate your time and attention. How many people, is it the first time to Bastyr Center? Yeah? Okay, well, welcome. You're welcome to our teaching clinic. Welcome to this space. I encourage you to spend a little bit of time just walking around the first floor and looking in the dispensary and other places around this clinic. We're excited to be able to now have access to this side of the building. There used to be an organization called Preventable that had their they did rehabilitation for patients with cerebral palsy and other musculoskeletal and neurological disorders, and we're really excited now to have access to this space to be able to bring more people from the community into the Bastyr Center for Natural Health in order to hopefully educate you and provide you some information on how you can improve your health naturally. So this morning we're going to talk about type 2 diabetes prevention. We're going to talk about the why do we want to prevent type 2 diabetes, and then also some tips on how we can prevent type 2 diabetes. So just a quick overview. I'll talk about some background on the state of prediabetes and diabetes here in the United States and really in the world. The rates are rising very rapidly around the world. Talk with you about what is diabetes, point out some diabetes risk factors, and then we'll go through some rules of thumb for diabetes prevention, including diet, some ways to become more active, talk about the importance of stress reduction, and then time permitting we'll talk about testing, some of the testing options that are out there, and specifically testing for blood sugar changes as well as more comprehensive testing to evaluate your risk for cardiovascular diseases and other conditions. So just one warning, I do have a tendency to be a bit long-winded and go over my time, so we'll try to contain the presentation into the 1 hour that we have and then open it up for some questions as well. I am very interested in having a discussion this morning, and so if you have questions throughout the presentation, feel free to pause me and ask your question. If I can't take it right in that moment, I'll be sure to let you know that I'll get back to it, and then remind me if I don't get to your question. So this is really one of the reasons why we want to learn more about diabetes and think about diabetes and how diabetes and heart disease are related, and that's because we know that most people actually pass from chronic diseases, from complications of chronic diseases in our country. That is, the leading causes of death are in most cases preventable. Ischemic heart disease or coronary artery disease is still number one. Lung cancer, secondary primarily to cigarette smoking, is number two. Then we get into stroke, which is of course a neurological change where we either have a blood vessel that busts or a blood vessel that gets blocked in our brain. COPD, this is chronic obstructive pulmonary disease. Pneumonia is often a complication of respiratory diseases. Then we start getting into some cancers, and then diabetes here, which is actually, I believe, number 6 or 7 for leading causes of death. But actually, diabetes dramatically increases our risk for stroke, as well as dramatically increases our risk for ischemic heart disease. So diabetes actually impacts several of these other top causes for death as well. More importantly than the cause of death is what is the cause of the disease to begin with, and the chronic disease. And we know that behaviors precede chronic disease, that it's really our personal health behaviors, the way we take care of ourselves, the way we live our lifestyles, the choices that we make in terms of using tobacco, not using tobacco, drinking alcohol, not drinking alcohol, etc., poor diet and inactivity, that these behaviors actually impact our risk for developing these chronic diseases very dramatically. And so this brings us to what is type 2 diabetes. And at its most fundamental level, type 2 diabetes is an impairment of our bodies of being able to produce the energy that we need from the food that we eat. And this happens at the cellular level. It happens in every tissue in our body. The reason that it happens is because we become resistant to a hormone called insulin. Insulin is made in our pancreases, and insulin helps bring sugar out of our bloodstream and helps get it into the tissues where we need it and where we use it for energy. So diabetes, many people think of diabetes as the hallmark sign, which is having blood sugar that's too high, and that's true. However, there are challenges in our cells of being able to actually just make energy from that food. That's a hallmark of diabetes. And then one thing that many people don't know is that even in type 2 diabetes, that there's actually a deficiency in our production of insulin that goes along with type 2 diabetes. And a lot of people know of type 2 diabetes as a condition of insulin resistance, that the hormone just doesn't work as well. Fewer people know that we actually end up making less insulin even in type 2 diabetes. A lot of people are familiar with type 1 diabetes, the autoimmune disease where the pancreas is actually damaged and people need to take extra insulin in order to keep their blood sugar normal. But it turns out that type 2 also has a deficiency of insulin as well. Why? That's a very good question. And I'm going to talk a little bit about the mechanisms as to why, but the short answer is that when the blood sugar gets really high, it causes inflammation in every vascular bed of our body. It doesn't matter whether it's our brain or our pancreas or our kidneys or our extremities like our fingers and toes. We know that this inflammatory change happens, and that inflammatory change actually stimulates the beta cells in the pancreas, which are the cells that make insulin. It stimulates them to stop secreting their insulin normally. And instead, the cells stay alive, but they no longer secrete insulin. They still make it. We've done special testing in clinical studies and animal studies where we can label the insulin and see whether or not it's still being made. And it is, in fact, being made, but it's no longer being secreted normally. And it really comes down to inflammation in the blood vessels. And we'll go through some mechanisms of that. Talking about blood vessels, diabetes, the reason we're most concerned about diabetes is because diabetes dramatically increases the risk for having a heart attack and having a stroke. And we just saw that heart disease and vascular diseases are the leading causes of death in the developed world. And then you add diabetes on top of that, and now we're increasing that risk 2 or 3 times above what it is normally without diabetes. So it very, very strongly increases our risk for having these major blood vessel diseases, these macrovascular diseases. However, diabetes also increases the risk of developing problems, or we call them complications, in our small vessels. And this includes the small vessels of the eye, the small vessels that lead to our kidney, as well as the small vessels that supply blood to your extremities, to your fingers and toes, as well as the vessels that supply blood to all of your nerves. And so this leads to many of the complications that we've heard about with diabetes, including vision problems that can lead to blindness, kidney problems that can ultimately require dialysis, neurological problems which can become very, very painful. We're learning a lot about the similarities in the causes behind type 2 diabetes and Alzheimer's disease, and we're even learning that the changes that happen with diabetes can lead to cognitive declines, impaired memory, inability to think properly and clearly. And then also, because of the limitations in blood flow that happen with diabetes, diabetes can also lead to amputation of the limbs. So very, very serious complications from the disease. Again, just briefly about insulin and blood sugar. Insulin is really the key that fits into the lock that allows the doorways to open between your bloodstream and your cells, that allow that sugar to go from your bloodstream into your tissues. So in the absence of insulin, there's no key to turn the lock, and it really is a lock per se. We have a receptor for insulin that insulin fits into just right, and when that receptor is bound, the doorways open. So it's very much a key and a lock. What are the major risk factors for diabetes? I bet many of you know them already. But the most spoken about risk factors are, of course, leading a sedentary lifestyle. This is not just the absence of exercise, of dedicated exercise. We know that. We're studying this in epidemiological research now, that while dedicated exercise is certainly a protective factor, just being sedentary and living an inactive life is also a risk factor. So finding ways to stay engaged in our life, making ourselves get out and be active, expanding our livable area, continuing to learn, continuing to appreciate and enjoy the life that we have are all protective. Simply being overweight or obese we know is a major risk factor. Following a poor diet that's high in fried foods, sugary foods, as well as animal-based proteins, meat proteins, increase our risk. The strongest risk factor historically has been age, and we saw type 2 diabetes really start to increase once we reach about age 45 and then continue to escalate from there. However, because we're seeing many of these changes happening earlier in life, we're also starting to see type 2 diabetes happen much earlier in life, including children. I just had a colleague tell me the other day that they diagnosed type 2 diabetes in an 8-year-old child. Which that child was about 200% of their normal weight for their age. They did not have good nutrition. They ate very poorly. But type 2 diabetes in an 8-year-old child is, I think that's something that we need to try to change as a culture. Family history, of course, increases our risk. There are genetic components, and I'll talk briefly about the influence that genes have and the influence that genes don't have in developing type 2 diabetes. We also know that there are certain racial and ethnic groups that are at-risk groups. We know that Black Americans, Latino Americans, many of our native populations, including our Northwest natives, are at increased risk for developing type 2. And then some less commonly known risk factors, including cigarette smoking, again, because of this vascular inflammation process that happens. Depression. Depression is one of these issues where there's sort of a chicken or the egg question. There's evidence that both having depression increases risk for developing diabetes, and then there's also evidence that having type 2 diabetes increases risk for having depression. And so we quickly get into this cyclical relationship between the two. We know that treating depression with antidepressants doesn't help people change their behaviors very much. That's been studied in clinical trials. We don't see that antidepressant medications prevent diabetes per se. And so this just tells us that there's something else going on. There's something else beyond just the neurochemical in the brain and binding the right receptor in the brain that's going to help make all these things better. There's something deeper, something else that's leading us to say perhaps live a less active lifestyle or perhaps make less than optimal dietary choices that may contribute to this development of diabetes. Chronic stress, we have some evidence of chronic stress, and I'll talk about that. And then, as I've mentioned, this increased vessel inflammation and increased liver inflammation. And I may or may not have time to get to this piece, but I'll try to. Yes?
Can I ask you a really quick question?
Of course.
So they're finding that people with HBC are becoming diabetic, and is that the ticket? Is that?
You're just to clarify, HBC, hepatitis?
HBC.
Oh, hepatitis, yes, type, right, hepatitis C. You know, that's a very interesting question. And what we know is that for patients who have, there's a measure, a liver enzyme that we measure to look at the amount of inflammation that is present in the liver. And I have a few slides on that at the end of my presentation. But we know that if a person has hepatitis C and they have increases in this particular enzyme, that their risk of having chronic hepatitis C as well as dying from their condition is much, much greater than people who have hepatitis C and have very, very low levels of this particular enzyme. And that's because the enzyme is called GGT, which stands for gamma-glutamyl-transferase, this long biochemical world. But GGT helps with our recycling of an antioxidant called glutathione that helps protect all of our vessels from rust or from oxidative stress. And so it appears as though there is this interaction in our liver, and anything that increases inflammation, whether it's dietary sources, cigarette smoking, or a viral infection, seems to reduce our reserves of this particular antioxidant, and then it makes other tissues in our body more susceptible to oxidative change and inflammatory changes. That was not a particularly short question, but hopefully we'll get to that again. Okay.
Yeah, that was a good start.
Okay. So we know that the development of insulin resistance and type 2 diabetes is very much a continuum, that we go through a progression from what we call normal glucose tolerance, this just means normal sugar metabolism, through a stage of prediabetes that we call either impaired fasting glucose or impaired glucose tolerance, which are what these abbreviations are for. Then we progress into a syndrome that's called the Metabolic Syndrome, where we begin to see not only blood sugar increasing, but changes in other risk factors as well. We see usually our HDL, our high-density lipoproteins, or our healthy cholesterol becomes quite low. Our low-density lipoproteins, our LDL, or bad cholesterol, becomes quite high. We also see things change, such as our triglycerides, which is a measure of fat in our blood. Our triglycerides become high, and then often blood pressure becomes high as a part of this process as well. And then as we continue to progress, we get into more full-blown type 2 diabetes. Okay. So here's just really briefly, here's a quick graph that shows this continuum. And first I'll orient you here to the legend. And so FPG stands for fasting plasma glucose, so this is just blood glucose. And if we're in the 79 to 89 range, this is normal. 90 to 99, this is starting to creep up a little bit. 100 to 114, this is our pre-diabetes state. 115 to 149 is right, it sort of straddles diabetes. Diabetes is right at about 126 or so is where we make that diagnosis. And then blood sugars of 150 to 349, obviously these are blood sugars that are much higher. So let's follow the curves here. So there we start with this magenta line, and what we're looking at is we're looking at time, and then we're looking at our release of insulin, our response to insulin. Okay, and this is after we give people in each of these categories a standardized amount of sugar. We give them a drink called an oral glucose tolerance test, which is just glucose mixed into liquid, just mixed into water. It kind of tastes like an orange soda without the bubbles. And so if you have normal glucose and you give an oral glucose tolerance test, you can see that this magenta curve is very, very high. We get a very robust insulin response. Lots of pancreas secretes lots of insulin. The orange one, kind of the next step, we see pretty close, really no difference between these curves if we look really carefully. If we get into the pre-diabetes state, now look what happens. Down here, we're seeing an impairment of what we call this acute phase insulin response, this very early insulin response. If we get into higher blood sugars, we see that this insulin response almost disappears. And then once we get into the range of fasting blood sugar, so blood sugar without having eaten, of 150 to 350 or 349, that insulin response almost disappears completely. So very much a continuum of progression of insulin progression of insulin resistance, as well as a progression of relative insulin deficiency. And so this is why we want to stop this cycle before it gets to here. Yes, ma'am.
The numbers to the right, how would they relate if those are A1c numbers?
The numbers to the right. So these numbers? Well,
the 24,
oh, to the right, these numbers, yes.
12.
Yeah, that's a good question.
What are those? Because when I think of A1c, your A1c is up and down.
Yeah. So it's a good question, and I have some content on hemoglobin A1c later. But to answer your question, hemoglobin A1c is a measure of our average blood sugar. It gives us an estimate of what our blood sugar has been over a 3-month period of time, and the A1c includes two components, really. It includes some contribution from our fasting blood sugar, which are these numbers, but then it also includes a contribution of how high our blood sugar goes after we eat, and so we end up getting this composite, okay? So this fasting number is often lower than our average number. But to give you an idea, when we look at an average blood sugar of about 150, 154, that is a hemoglobin A1c of 7%. Okay? And then it goes up 30 points for each 1% above that. So a hemoglobin A1c of, say, 8% is an average blood sugar of about 184, 185. Okay? So if we're looking at where is normal blood sugar, that is the absence of diabetes or the absence of prediabetes, is a hemoglobin A1c less than 5.7%. Okay. So now, more on the impact of type 2 diabetes. According to the World Health Organization, there are about, as in the year 2000, there are about 177 million people around the world that have type 2 diabetes. This is expected to almost double in about 25 years, by 2025. We know that there are about 23 million people here in the United States that have diabetes. We know that about double that number have prediabetes. I've already mentioned that it's the 6th leading cause of death, or was in 2002. Very, very shockingly, as many as 50% of people don't know that they have type 2 diabetes and don't know that they have prediabetes because they've never been tested. So this is alarming that so many people have this risk of a major chronic disease, and yet they don't know it. So you might say, well, why has this happened? Why are we seeing this increasing trend? And in order to understand that, we have to really look at what is happening to the body weight of our people, of folks here in North America. And so this slide, this is 1999, and you can see down here at the bottom is our legend. And so this is the percent of the population within a given state that is overweight or obese. Or actually, I'm sorry, this is specifically obesity. So this is a BMI greater than 30. And you can see that here in the blue, or light blue, it's less than 10. 10 to 14, 15 to 19, and then the yellow color is greater than 20. So this is 98, then we go to 2000, Then we go to 2002, we add a new color down at the bottom. Now it's greater than 25%, we're starting to see in some states. Okay, this is 2004. 2006, we add yet another color. Now we're at greater than 30%. Still greater than 30%. And so epidemiologists refer to this as the reddening of the United States, right? That we're seeing a good bit of the country is now in excess of 25 to 30% of the population of their states that now have obesity. So this isn't just overweight. Overweight is an earlier stage where our BMIs are, say, 25 to 30. But once we actually reach obesity, and now up to 25 to 30%. So it's really not surprising that we're seeing these increased rates of type 2 diabetes. And so how does obesity impact our blood sugar and things? Well, we used to think that fat tissue, that adipose tissue, was just a storage tissue, that our body would just take everything extra and it would just dump it into our fat cells and it would just kind of wall it off, and we would continue to accumulate it, but it was sort of isolated from the rest of our body. And then we learned that that's actually not true. That fat tissue that also has a hormonal-like effect. That fat tissue is basically an endocrine organ all by itself, and it produces its own signals and its own chemical messengers to other parts of the body. And we call these cytokines, or when they're coming from fat tissue, we really call them adipokines. And these communicate with our immune systems, and they tell our immune systems to make all kinds of changes. And you can see down here that some of these changes include reducing our sensitivity to insulin, reducing anti-inflammatory effects, so therefore we become more inflammatory, and reducing some atheromatic. That's kind of an interesting word. I don't think that's a real word, but an atheroma is the development of a clot or development of plaque in our arteries, and so these cytokines actually reduce the anti-atherogenic properties of our body, and therefore we begin to create more plaque in our arteries. I think this is another good reason to prevent type 2 diabetes, and that's because the state of medical care for type 2 diabetes in our country is atrocious. And I say that with great confidence. I've studied this a lot. I've reviewed the literature in this area. Our management as a medical care system in this country is very, very bad. And fewer than 40% of patients with type 2 diabetes, of all 23 million of those patients, fewer than 40% are at their target for their blood sugar. And if we look at patients who are at their target for blood sugar, blood pressure, and blood cholesterol, fewer than 10% of people around our country have all three of these risk factors under control. So I just think that this is shocking given this next statistic, which is that $178 billion a year of our annual healthcare costs go into treating this disease and its complications. So just for your record, that's actually 1 out of every 6 healthcare dollars in our country. 1 out of every 6 goes to treating this disease, and yet fewer than 10% of those patients are under control in terms of their blood pressure, blood sugar, and blood lipids. So, this is the kind of thing that naturopathic doctors and Bastyr and other alternative health providers, we get a lot of slack for not, having evidence and for needing to justify ourselves and all this other stuff. And I say, what kind of double standard are we living here? Where we have all of this money, all of this technology, special testing, drug development, everything else that goes into treating this disease, and yet less than 10% of patients are actually in it. I think that's a terrible atrocity. This is just looking at some of the costs that are related to diabetes. Of course, type 2 diabetes itself, very, very expensive, over $50 billion. Add the other complications that accompany obesity, things like arthritis, as well as other chronic diseases, and again, over $50 billion. Coronary heart disease itself, almost $40 billion. Hypertension or high blood pressure, almost $20 million. And then the complications of stroke, again, almost $20 million. So very expensive. If we look at what most of those costs or what has changed in our healthcare spending over time, we can see it's really this red line that has increased dramatically since the mid-90s. And of course, this is the cost of prescription drugs. The real issue with this, all of this, the development of type 2 diabetes, the associated costs, the impact that it has on our healthcare system, is that we have known for several years now, really since this publication in 2002 called the Diabetes Prevention Program, that we know that type 2 diabetes is preventable by changing our lifestyles. Around the country, there were these large demonstration projects at major academic medical centers, and they took over 3,000 people with pre-diabetes, and they randomized them to either a drug called metformin, a placebo, or an intensive lifestyle modification program. And the lifestyle modification program targeted only 7% weight loss for those people, and recommended that they try to get 150 minutes of exercise per week. So that sounds like a lot when you think about it per week, but really that's 30 minutes a day for the work week, so 5 minutes, or the 5-day work week out of the day, only 30 minutes a day. Or if you were to do it in one block, this is about 2.5 hours. So you could go, out on, say, this afternoon and go cross-country skiing for 2.5 hours, 3 hours, and you've already exceeded actually your weekly amount of exercise just in that one single hike or ski or what have you. So it's really not too terribly challenging to get that amount. But the results were that 74% of the people who were in the lifestyle group were able to meet that goal, and that after 3 years, the lifestyle intervention group had almost a 60% reduction in new cases of type 2 diabetes. The metformin group only had a 30% reduction in new cases of type 2 diabetes. So clearly the lifestyle intervention was superior to starting medications early. What we've seen since is that if patients stopped taking the medication, then not surprisingly they went on to get type 2 diabetes very rapidly. Because fundamentally they haven't changed anything about the way that they're living their lives. All they do is take a pill. So we'd like to do things a little differently.
So for the lifestyle exercise thing, are we talking 30 minutes of going for a walk? Or are you talking treadmill?
Yeah. There's the caveat to that is there's a difference between weight loss versus weight maintenance. And for weight maintenance, we recommend 150 minutes of exercise per week, and that ideally is moderate intensity or higher activity. So that would be brisk walking, it would be jogging on a treadmill, it would be something that gets your heart rate up to about 60% of its maximum heart rate. Okay, and that's age dependent. If you're actually looking at weight loss, it does take more intense exercise, and it does take longer periods of activity in a given week in order to do that. But we know that every amount of activity matters, and actually recently just the effects of brisk walking were studied, and even brisk walking has a substantial benefit on our metabolic rate and helps us maintain our weight and even helps lose weight if you watch your calories at the same time. So walking counts. Okay, so diabetes is preventable by lifestyle choices, and yet we still see publications like this. And I am absolutely appalled by this publication. This was published just last year in 2010 in the American Journal of Cardiology, I might add. So this is one of the preeminent cardiology journals in the United States. And the title speaks to itself: Can a statin neutralize the cardiovascular risk of unhealthy dietary choices? And then they went on to publish this particular figure. That is the MAC statin. I'm neutralizing it. I completely agree. With this message, no tablet can completely neutralize the harm to your individual health from eating unhealthily. Better ways to reduce your risk from death from heart attack include eating healthfully, exercising, maintaining a healthy weight, and not smoking. See your doctor for complete advice. And yet they transpose these, they're right there next to each other. And what kind of messaging is this that we're giving the public? And you could say, well, that's buried in a cardiology journal. Nobody ever reads that. But in fact, so this is The Guardian. It happened to be some cardiologists from the United Kingdom who did that study. And it was just an observational study where they did all this statistical modeling to see if taking a statin would offset these risks. But this is the message to the public. That doctors are making this recommendation, and that they're even encouraging restaurants like McDonald's and other fast food restaurants to offer a statin, say in a Happy Meal, that you would take before you eat your meal. I'm appalled by this. Like, I can't believe, we pay people a lot of money to do this and make this recommendation. You pay them through your health insurance premiums, actually. So it leads a lot of patients to this situation. So I'll just give you
This is pretty interesting. I love the movie.
So, I can operate or you can go on a strict diet. Well, you better operate because my insurance doesn't cover the strict diet. Right? How many, I mean, I'm sure all of you have had some experience with this.
Wellness stuff in my plan.
Right. Well, the good news is that we all live in Washington State. And Washington State is a very unique state from a healthcare policy perspective because we have a law that was passed in 1997 that's called an every category of provider law. And what that law states is that insurance companies must offer a plan that covers each medical service independent of what type of provider delivers that service. And what it means is that for citizens of Washington, you have access to different types of providers that can help sort of change the course of this and help provide you access to different sources of information, including information on how you can make dietary and lifestyle changes. So this is a schematic of the clinic that I run here at the Bastyr Center for Natural Health, where you begin your care seeing a naturopathic doctor. And then within the Bastyr Center for Natural Health, we have all of these other specialty providers. We have acupuncturists, we have dietitians, this got cut off a bit. We have other specialties, including homeopathy and physical medicine and environmental medicine. We have licensed psychologists and counselors that can help with counseling and stress management and treatment for depression. We also have a medical doctor here that is a family medicine doctor. His name's David Kiefer, that we keep on hand, and he does some minor office procedures and he does some medication consults and some other things for us. And then we also, of course, refer outside to the greater medical community. Although I criticize the cardiology journal and that particular publication, cardiologists have their role, and they, of course, have very sophisticated imaging and can perform very sophisticated, very life-saving interventions for people who are at risk and who really need those interventions. And we refer to these specialists all the time, whether they be cardiologists or nephrologists or other specialists as needed. This is sort of the naturopathic practice pyramid, where the basis, the foundation of the pyramid is always going to be focused on patient self-care, their own management, and trying to empower patients to make choices and have a voice in their own healthcare decisions. This is, of course, followed by actively promoting health and wellness within our clinical delivery, within the advice that we give patients. We then, of course, have various nutritional, herbal, and homeopathic medicines. And then here in Washington State, naturopathic physicians are able to prescribe most prescription drugs. This includes the first-line medications for diabetes, the first-line medications for cholesterol and blood pressure, antibiotics, things like that. And then, of course, surgical interventions as needed. So I think that we've talked a bit about the causes of diabetes, and now I'm going to get more into some of the technical mechanisms, and I'll try to keep it fairly superficial, not get it too technical. So if it's confusing, please ask a question. But we know that that the causes of diabetes have to do with our lifestyle, and that on one hand we could frame it as overconsumption of energy dense, this means really high calorie food, so overconsumption of very high calorie food, yet micronutrient deplete foods relative to our activity level. And this is important, relative to our activity level, because there are a lot of foods that are very appropriate and even necessary and do your body good if you are very physically active. You know, if you're a marathon runner and then you go out and have a bunch of white bread or drink a soda, have some candy, all those sort of things, your body as a marathon runner just absorbs that sugar so quickly, and you need it to replenish your muscles and replenish the fuel that you have in your body. And so if you're that active, then eating straight sugar, I'm not saying it doesn't do any damage or that it's not, or that it's good for you, but it's not as bad for you because your energy level is so high and your body really needs that fuel to metabolize it. But if you're not a marathon runner, and in fact if you don't get really any activity per day in a given day, then your body doesn't really need that much energy. You know, like it doesn't really take that much energy to flip the remote. It doesn't really take that much energy to go out and get the mail. Like we think about, oh, I'm active. I went out and got the mail. I do a little gardening. Those things are important. But when it comes down to really burning energy and really using your muscles and burning fuel and working your body, those activities don't really cut it. And therefore, the amount of carbohydrates, especially carbohydrates, that your body needs to replenish its fuel supply, very, very little. There's one of my colleagues, or one of my mentors going through naturopathic training used to say that there are essential fats, which is true. There are essential proteins or amino acids, which is also true, but there really aren't essential carbohydrates. And that's actually true. Your body can make glucose from protein. Your body can make glucose from different amino acids. Your body can burn fat as fuel. But when carbohydrates become essential is when your activity levels are very, very high and you need to restore your reserves. But day to day, your carbohydrate needs in the absence of activity are very, very low. Said differently, underconsumption of nutrient-appropriate foods to express your genetic potential. How about that? Expressing your genetic potential. So, a lot of people think, or a lot of people sort of attribute diabetes and causes of diabetes to our genes. Right? You've probably all heard that. Well, it's my genes, it's my family history. I'm destined to become type 2 diabetic because it's in my family. Well, guess what? Every gene in your body is controlled by the environment that gene is in. Every one. No gene in your body acts independently. Every gene is controlled by your environment. So, you're absolutely right that if you follow a similar lifestyle to your parents, if you have similar risk factors in your life as what your parents had, and if perhaps things aren't changed, then you are likely to develop type 2 diabetes and the complications thereof. However, you have the power to control those genes. And I'm not going to spend time talking about the research in detail, but the investigator that has shown this to most convincingly is Dean Ornish, who's a medical doctor, who's a cardiologist down in Marin County in California. And he has shown this scientifically, that they have taken patients with established coronary artery disease, so severe blockages in their coronary arteries, and taken them through an intensive lifestyle change program. And his research group actually demonstrated substantial reversal of coronary artery disease by changing people's lifestyle. The other thing that they've done in his research was they actually looked at which genes flipped on and which genes flipped off before and after that lifestyle intervention, and they saw dramatic changes. That before the lifestyle intervention, all of those inflammatory genes and whatnot that we were talking about before, all of those were flipped on, and after the lifestyle intervention, all of those genes were flipped back off. So genes are important, and genes do, to some degree, help determine our genetic potential and our risk for developing diseases, but we are not under the control of our genes. In fact, our behaviors and our choices control our genes and their expression. And then this last way to frame the cause is an overconsumption of inflammatory foods that are high in glucose, fat, and age products. And age, in this case, stands for advanced glycosylation end products. And now I'm going to talk to you about those things in a lot of detail. Yes?
I know a lot about Dean Ornish, and I also know that he's strict vegan and no oils and all that sort of thing.
Yeah.
I hope you don't agree that that's the only way to handle it.
No, I don't. And I'm going to give you some rules of thumb, specific dietary rules of thumb, and we'll talk about oils. Okay. So in order to talk, because my research very much focuses on this vascular inflammation piece. I am a researcher with Bastyr University, and I'm an affiliate researcher in the Division of Cardiology over at the UW. I've done some clinical trials and also done some work learning about new biomarkers of inflammation, including the enzyme in the liver that we were talking about earlier. And so let me spend a minute just orienting you to your own arteries. Okay, so this is a cross-section or a schematic of a given artery. You can see you have all these different layers in your artery. The layer that we're most interested in, or that I'm most interested in, is this very inner layer, and it's called the endothelium. And you could think of it almost like a filter, because this is the layer of your artery that everything in your blood, like this is what it hits first. This is what it comes in contact with first. And it serves a bit as a filter. It's a very, very sensitive layer. It's only 1 cell thick. And it isn't very good at regulating the amount of glucose that comes into it and out of it. It's almost completely open to glucose. And so therefore, when your blood sugar gets really, really high, this layer of your arteries undergoes some significant changes, and I'm going to talk to you about them. Okay. So again, now this is, again, your endothelium. Here it's nice and healthy. You see your wider artery, all these other layers, but your endothelium, everything looks good. Then we get into mild atherosclerosis, okay? And the reason I'm talking about atherosclerosis here is because we know that diabetes increases the risk of developing atherosclerosis dramatically. And at the end of the day in diabetes, it's really vascular health that we're most concerned about, and improving your vascular health, both your small vessels and your large vessels. So that's why I'm focusing on the vessels. So mild atherosclerosis, we're seeing this plaque start to accumulate. It actually begins to accumulate in a layer called your intima media, which is the middle layer. And then we get to severe atherosclerosis, where we see this plaque start to grow, and we even see narrowing of the inside of the artery. This is the lumen of the artery, and we see that narrowing happen. Okay. So how does this process happen? And we're going to start down over here. Well, the first step in this process is exposure. And the exposures that we know that cause disruption of the endothelium include sugar, fat, as well as these glycosylation end products. And when we eat these and they enter our bloodstream, they create increased inflammatory mediators and increased free radicals. And so we're going to designate free radical as this red star, okay? And free radicals are cause oxidative damage. And so oxidative damage you can think of just like rust. That when something made out of iron gets rusty, that's because the iron is causing a reaction with the air, and it's actually causing that rust to happen. So you can think of this free radical process and this oxidation process happening inside your arteries exactly the same way. It's literally causing rust inside the artery. Okay? So this free radical interacts with your LDL. People know that their LDL is bad, right? That's the bad cholesterol. So this free radical interacts with LDL, and it causes oxidative change, causes the oxidation of LDL, or oxidized LDLs, to form. And these oxidized LDLs trigger our immune cells. And so here's this is literally an electron micrograph of an immune cell coming in, and it's about to suck up this particle here, okay? So we're going to pretend that this particle here is an oxidized LDL. It happens to be a viral particle, but that's okay. So this is an oxidized LDL. So our immune system gets triggered and engulfs this oxidized LDL. And then it starts to, within that immune cell, it starts to accumulate these oxidized LDLs. And we can see that here. And then eventually it has to do something with all these stored byproducts. And so what does it do with them? Well, it stores them into the intima media of your arteries, because it has to get rid of it. It's basically junk. And if it stays in circulation, then it's going to keep activating the immune system, and the inflammatory process is going to become very difficult to control. So it stores it right here in your arteries, gets it out of circulation. And you might say, well, where have I heard of this process happening before? And this is where we do it all the time, right? We have a perfectly clean artery, it becomes oxidized, it gets engulfed, it accumulates, and eventually we have to store it. So we know that this process happens. So the question is, how does it happen? And I talked to you briefly about the exposures. These are two graphs from research that was done by an Italian cardiologist named Antonio Ceriello. And Dr. Ceriello did really the first research that showed an inflammatory reaction from certain foods. And what he did was he took that same sugar drink, that same oral glucose tolerance test, and he mixed it up with whipped cream. And then he fed it to people, and then measured various inflammatory reactions or various inflammatory mediators for several hours after that meal. And so here's glucose, and here's triglycerides. Triglycerides are just fat. And this is where he had the folks drink the drink, and then you see the glucose increase, and you see the triglycerides increase. Triglycerides are a little slower to increase than the sugar is. And then in this plot, same time, same people, he measured two inflammatory mediators. One is called C-reactive protein. Some of you have probably heard about C-reactive protein. So one of them is called C-reactive protein. That's these triangles. Another one is called nitrotyrosine. Nitrotyrosine is an oxidation product. It's kind of a rust product that happens in the artery. And then the other thing he measured was whether or not the arteries could dilate properly, or whether their dilation was impaired by this particular meal. And you can see here that the C-reactive protein increased dramatically over the 4 hours that followed that meal. Nitrotyrosine, this oxidation product, increased dramatically the 4 hours after the meal. And the ability of that artery to dilate normally was reduced dramatically for 4 hours after that meal. And you might say, well, yeah, that was for research. How representative is that meal, that oral glucose tolerance test mixed in with this whipped cream? And I would encourage you to look around a little bit and see just how common that is. 75 grams of glucose sounds like a lot, but when you start really paying attention to the amount of carbohydrates and the amount of sugars that are in, say, a can of soda, or even an Odwalla juice for that matter. Oftentimes, even Odwalla juices, and fruit juice may have some special qualities that help it be more protective, but we don't really know that for sure. So a given Odwalla juice may be, or any other brand, I'm not picking on Odwalla, there's any fresh juice that doesn't have the fiber in it anymore, the servings of sugar in some of those juices can be 30, 35, 40, 45 plus per serving, and then there's 2.5 servings per bottle. And so it isn't actually that uncommon to drink 75, 80, 85 grams of sugar within a very short period of time. And you might say, well, okay, well, what about the fat? Well, the fat's it was about 700 calories worth of whipped cream. And you say, well, that's a lot. Well, you know, Starbucks has to advertise its nutritional information now. And so take a look at some of their drinks. And I think that you'll find that this actually isn't that uncommon. Okay. The other thing that Ceriello did that's very important was he repeated these experiments in people who didn't have diabetes and then also in people with diabetes. And he saw the same reaction. People who did not have diabetes, they still have these increases in inflammatory mediators and oxidative stress mediators, but they didn't go quite as high as they do in people with diabetes. That makes sense, right? Because people with diabetes, they're starting much higher to begin with, and so that you add a challenge and they're just going to go higher yet. Also, people with diabetes, the reactions tended to last longer, and again, their baseline status of all these inflammatory mediators was much, much higher. But the same reaction happened in people without diabetes. And so that kind of gets you thinking, doesn't it? It's like, wait a minute, that means that I don't have diabetes. I'm susceptible to this change just based on my meal choices, and it happens this quickly after my meals. Within 4 hours, all this stuff is going on. And I think it really makes us think differently about our food that we eat, and also that we can kind of see, you can sort of imagine how this progression is cumulative, right? You do this every now and then, it's probably not that big of a deal. You do this every day, it starts to become a big deal. You do it every day for 45 years, it becomes a very big deal. You do it every day 3 times a day for 12 years, and now it's a very big deal for a 12-year-old, okay? And these foods, obviously in this research study, these foods, this oral glucose tolerance test and this whipped cream, they didn't contain any protective nutrients, anything that may offset this. They didn't have any vitamins in them. They didn't have any colorful pigments or other things, any antioxidants that may reduce this effect. And so it also leads us to think, well, maybe there's things that we can do to reduce this amount of inflammation that happens. Okay. I spoke to you really briefly about advanced glycosylation end products. This is a whole big pot of advanced glycosylation end products. And how many of you have ever browned onions in a saute pan? Right, okay. So glycosylation happens when you mix foods that have sugar in them with foods that have protein in them in the presence of oxygen, okay? So basically, it's just cooking food does this. If you brown onions in a pan, they get that caramelization, that browning reaction. You put a piece of bread in the toaster, you toast it, you heat it with oxygen, the bread that caramelizes, you just made toast, right? Well, you also just made a whole slab of advanced glycosylation end products, okay? Yeah, right, yeah.
Onion like that all the time to flavor everything. I mean,
Well, so you know,
four big onions like 3 times a week.
Yeah. Well, and so I picked on onions because most people are familiar with onions. Onions actually have some polyphenols in them that may be protective, and one of those polyphenols is called quercetin, and onions have a lot of quercetin in them. And onions help, or not onions, but quercetin does help reduce oxidation and oxidative change. And so while I picked on onions, onions are probably not the worst of the worst. It's just an example. So what happens when you give meals with high levels of advanced glycosylation end products to people? Well, this study, what they did was they took a meal that was, all it was chicken and carrots and potatoes. And they either roasted it, so they just put it in the oven and broiled it, or they poached it. That's it. It was a difference in cooking style. Chicken, carrots, potatoes. Not that, you wouldn't think that, oh, that's a really unhealthy meal. You wouldn't think that. It wasn't fried. It's just roasted. So they saw, of course, this increase in advanced glycosylation end products. We can measure them. We saw an increase in oxidative stress, more rust.
Now, for which one is which here?
Right, so these triangles are the high age meal, or the meal that has higher amounts of glycosylation end products. And then here, this is where we're measuring that same action of the blood vessels, whether or not they can dilate normally.
What's this contrasting roasting
And poaching.
Which one's which?
The roasting is the triangles,
Okay.
and the poaching is the open circles. Okay. Exact same meal, exact same number of calories, just cooked differently. And these are the changes that happen. Okay. So, all of this together leads to, this is my conservation of donuts hypothesis, right? That you have a choice in your life, right? If you have, let's just say that in your given life, in your life, you can eat 100 donuts. And you get to choose whether or not you eat all 100 of those donuts at one time, or if you eat 100 of those donuts throughout your entire life, okay? And donut is just an example food, right? It happens to be a good example of this concept because donuts are really high in sugar, they're really high in fat, and because they've been fried in most cases, they're also really high in advanced glycosylation end products. So if you were going to choose an inflammatory food to pick as an example, a donut is a really good example, okay? So if we were to look at this differently, you might say, well, somebody with average fitness, we'll just start with the yellow, if they eat one donut, this is a donut intake, and this is just an example, this is not real data, okay? So donut intake, this is number per day, okay? If you're an average fitness, you eat one donut per day, you can see that the age at which you get metabolic disease is going to be very, very low. If you eat very few donuts per day, the age at which you get metabolic disease is going to be much higher, okay? If you have a genetic disadvantage, well, you're down here. You can't get away with eating as many donuts per day. You're going to get diabetes or some other metabolic disease earlier in your life because of your genetics, all right? If you're at a genetic advantage, well, maybe you can get away a little bit longer, eating a few more donuts a day. But at the end of the time, at some point in your life, you are very, very likely to end up getting a metabolic disease like type 2 diabetes. And by changing our lifestyle, this has been shown that you can actually offset this genetic disadvantage, okay? So if you make your lifestyle more healthily, you can actually shift yourself over here. But the converse is also true, that if you start off with a genetic advantage and you don't follow a healthy lifestyle, then you're going to end up back here. I had a patient the other day, 60, she was in her mid-60s. She was Japanese in ancestry, and we were talking about her risk factors. And she said she was talking about her parents, and her parents, her mother is 104 and living well, and her father was 96 and also doing pretty well, had some complications, but was 96. And she was in her mid-60s and has type 2 diabetes. And we were going through some of these dietary things, and she was saying, well, my parents are 104 and 96. They're doing so well, I don't really feel like this matters for me. And so the question is, well, what was your parents' diet like? How has your parents' diet been different than what your diet is now? And her parents' diet was very much a traditional Okinawan diet. And her diet as a child was a traditional Okinawan diet. But now she says, well, I just love the Western diet. I've adopted the Western diet. And what is the relative contribution of the Western diet versus my genetics? And we know this. There's this interesting area of research on longevity and aging and telomere length, and there's these genetic ends of your chromosomes that tell your cells whether or not they should keep replicating or not. And we know that metabolic disease shortens these telomeres very, very quickly, very, very early. So it actually tells your cells to stop repairing and stop replicating themselves. Excuse me just a minute. I'm going to keep talking if these guys are interested, if that's okay with you back there.
Yeah, just bring these to the early 7 hour. Again, fill out one of these cards in front of you. You can use that for 10% off. That's the dispensary. You turn those into us, and you can let us know if you want more information about upcoming talks. We have a talk coming up April 23rd about detoxing your home, identifying common household hazards. So that's another talk that's coming up. So I'll just let him keep talking. But for anyone that needs to leave, if he was planning on leaving at 11:30.
It's 11:30 now.
How much longer do you think it'll be?
I'm going to try to get it done in a half an hour or less. Okay. This is actually where I'm getting to the tips. So if you can hang in there, I know it's taken me a while to get to it, all the build up, but here's the meat, all right, so to speak. All right, so food and nutrition gets very, very complicated, right? Like depending on who you talk to, somebody will tell you, well, you have to eat a low glycemic index diet. Well, you have to eat a low advanced glycosylation end product diet. Well, you should really balance your glycemic load, or you should really think about acidic foods versus basic foods, or what about the foods I'm reactive to? All these different things, and it gets very, very confusing. And so instead of that, I like to give a few rules of thumb on healthy diet, cardiovascular preventive diet or protective diet, and a diet that all signs point to it being protective against developing type 2 diabetes. And so how many of you have heard this recommendation to follow the rainbow, eat 5 to 7 servings of colorful fruits and vegetables a day? Right. So there's a lot of people know this message, and yet we don't know exactly how these pigments are protective. Some people think it's the carotenes, the beta-carotene, alpha-carotene, lutein, these colorful pigment fractions in food that are antioxidant and help reduce this inflammatory stress. It turns out that carotenes actually are not very potent antioxidants, but in order to try to find out why these pigments may offer some protection, I actually did a randomized controlled clinical trial that we just completed. I just looked at the results the other day. And we randomized 60 adults here in Seattle. This was done at Bastyr and the University of Washington. We randomized 60 adults who ate fewer than 3.5 servings of fruits and vegetables per day to one of 4 groups, either a placebo group. We used 2 natural mixed carotene supplements, so this wasn't just beta-carotene, but it was all of the fractions combined, or small daily vegetable-rich meals that we designed to be high in carotenes, and we actually provided these meals to participants. And we followed them for 28 days, and then we measured whether or not their blood levels of these carotenes changed. But what we were really interested in is what happens to their oxidized LDLs or to their LDLs after they eat a meal. And we actually fed them an inflammatory challenge meal. We fed them 2 sausage, egg, and cheese McMuffins, a large Coca-Cola, and a hash brown for breakfast. And this is what we found. And I'm not going to tell you which group was which because I can't. But I do want you to know that there was a significant response in that our placebo group didn't really change. But at the end of the month, 2 of our groups, we saw dramatic reductions in the oxidized LDLs that followed that meal. And we don't know exactly which pigment is responsible for this change yet. It may very well be the combination of pigments that's responsible for the change. But we see reductions in all 3 of our mixed carotene groups, and we saw very, very potent reductions in 2 of our groups. So more information on that to come, and we will, of course, publish our data and hopefully present it again. So we know, at least we know, that the pigments in colorful fruits and vegetables, provided it appears as a supplement and as food, offer some protection against this oxidized process that happens to your LDLs after you eat.
Cooked or uncooked,
Does it, the vegetables?
Yes.
Carotenes are actually pretty stable. So I think that a lot of people are really interested in raw foods and eating more raw foods. I think raw fruits and vegetables are the best way to eat them, but cooked is fine, and it's better to get in cooked fruits and vegetables than to not have them at all. So the cooking process doesn't break.
Happen with the onion.
Same thing doesn't happen with the onion?
Yeah.
Well, you know, it can, but at the same time, like we know that just eating more fruits and vegetables, cooked or uncooked, is protective. So just get them in. And if you can get them in raw, all the better, but just get them in. Okay, so now on to oils briefly. So use good oils, quote good oils, and as little as possible. All right, we did not evolve pouring large amounts of oil into our food and cooking with oil and all of those things. It's not the way, I mean, there is no oil tree or oil bush out there on the savannah, right? We get nuts, we get seeds, we eat them that way historically. But now through the wonders of modern technology, we can get all these great concentrated oils out and we can consume them in large quantities. Well, this has never really happened before to the human species. This is brand new, relatively speaking. And so it's important to use good oils and to be really careful about which oils you cook. Good oils are oils that are high in unsaturated fats, and especially polyunsaturated fats. And these include oils like olive oil, avocado oil, uncooked flaxseed oil, grapeseed oil, walnut oil, and fish oils. And then bad oils are, especially bad oils, are oils that are hydrogenated or trans, and you can read it on the label: partially hydrogenated cottonseed oil, partially hydrogenated palm kernel oil, etc. Butter, corn oil, shortening, lard, cottonseed, soy, and animal fats. These are considered bad oils. These are inflammatory oils. Now, there are a few caveats in that some people now are pointing to lard, and they're kind of asking this question, well, what about lard? Because lard is a saturated oil, and because it's saturated, it doesn't oxidize. And so there's a bit of a renaissance of coming back to animal lard that's coming from animals that were grass-fed or that were raised with different food supplies. And there's some suggestion that lard that comes from those particular animals in small amounts may actually be better than, say, frying food in an unsaturated oil that's going to get all oxidized and changed. Yes?
Where is coconut oil?
Yes, lots of people are interested in coconut oil. And coconut oil, what's that?
Canola, it should be above fruit.
Canola and coconut, I hear about people using that more.
Yes.
An alternate to like that vegetable oil or something.
Well, canola oil is a reasonably stable oil at higher temperatures, and so a lot of times you will hear people about people cooking in canola oil. Knowing a little bit about this and having researched what changes happen in the body after consuming different oils, my recommendation is still olive oil. Even if you have to saute in oil, even for medium to low temperature sautés. Now, olive oil is not a good high temperature oil because it is unsaturated and it does oxidize. But olive oil also contains, especially the kind of green olive oil that's a little bit more fragrant when you smell it. Olive oil contains natural polyphenols, natural antioxidants from the olives. And those polyphenols in the olive oil actually help protect the liver and actually help reduce this inflammatory reaction that happens after you eat it. So olive oil is still my favorite. Yes, ma'am?
How can you get flax? I've heard that too, that you shouldn't ever eat flax.
Yeah, flaxseed oil is a highly polyunsaturated oil. And what that means is that, you know, oils are these long chains of hydrocarbons, right? It's not unlike, you know, oil that you pour into your car, and it's and depending upon the chain length and depending upon whether, well, let me back up. We call that oil saturated if all of those bonds in that long chain are single bonds and they're all they can't be modified. And then there are these other oils called polyunsaturated or unsaturated oils that have these kinks in them. They have these double bonds. And those double bonds are susceptible to oxidation. And so flaxseed oil is a polyunsaturated oil, meaning that it has multiple kinks in it, but when you heat it, that oil can become oxidized at those kinks. So that's why we're not supposed to cook with flaxseed oil.
So flax is more like a salad dressing?
Absolutely.
Or like in a protein smoothie? Or
Anytime it's raw.
can you just eat a teaspoon of it?
Sure.
And drink it?
Oh, yeah, absolutely. And similarly with flax seeds themselves, you know, sometimes...
Brine them.
Yep.
And sprinkle them, or, yeah, same thing, like salad.
You got it.
Rely on lard because it's saturated fat, and you need good butter, it would be somewhat
Yeah, butter is a little different because butter is not only the oil but also contains a lot of proteins. And those proteins, butter is actually a pretty highly glycosylated food because those proteins get cooked through the pasteurization process, and they get changed, they get modified. And so butter isn't great. I think that what would be better than butter is actually ghee from the Indian traditions, where they actually take the proteins away and you get the clarified butter. Clarified butter is almost completely saturated. It's actually really quite a clean oil, and for high temperature cooking or something that you really want that buttery flavor, a little bit of ghee is probably the most healthful way to do that. Omega-3 oils, many people know that they come from fish. That's just a reminder that they are essential. All right, nutritionally, they are essential fatty acids. And the last time I checked the definition of essential, it means that everybody needs them. And that there's no other way to get them. Like, you have to eat them. Now, some people are very good at converting the oils in flaxseed oil to the oils that we get out of fish. There are enzymes in our body that can do that. Some people are very good at doing that. Their enzymes work really well. Other people, they're not very good at doing that. Their enzymes don't work so well. So unfortunately, we can't really test that. And so we typically recommend to patients that they find, even if they don't have cardiovascular disease or diabetes, that either they have 2 to 3 servings of cold water fish. Certainly Alaskan fisheries are the safest. It's 2 to 3 servings of cold water fish per week, or they use a fish oil supplement. And the American Heart Association, this is actually their recommendation in addition to our recommendation, that they promote the intake of healthy fish and or fish oils for everyone, whether you're at risk for cardiovascular disease or if you have cardiovascular disease, then they actually recommend higher amounts. Unfortunately, very few people actually get this recommendation from their primary care providers. Our statistics suggest that only about 17% of patients are ever talked with about the need for fish or fish oils in their diet. Yes, ma'am.
What about the proportion of EPA versus DPA and that? Some say you have to have a high level of EPA, or that's not the range you should have.
Yeah, there's a lot of people that say a lot of things and make really dramatic, really strong statements about it has to be this and that ratio and this ratio and that ratio. My approach, my approach to this is that we still don't know. We still don't know the optimal ratio.
I have a comment about fish oil.
Yes.
I had visual disturbance because of my chronic health problems.
Mm-hmm.
And just like in the last couple of weeks, I started taking a fish oil multi. And I noticed that my eyesight, the problems that I've had are milder.
Oh,
so
fantastic.
I think it's true that the fish has something that helps your health. So that's just like something that is.
Thank you for sharing that. Yeah, the oils that are in fish, these polyunsaturated fatty acids, they help every membrane in our cell stay fluid. It helps it move properly, helps it signal properly. Where we know there's the greatest benefit is in the membranes of the cells of our heart. That it actually helps us keep us from developing arrhythmias. We talked about that process of normal dilation. It helps our arteries dilate normally to have more fluid membranes. It reduces the coagulation of our blood. It helps us, it actually thins our blood, if you will. We don't clot as quickly. We need these oils in every cell of our body.
Does it make any difference in taking it every day? Patients said it take a pouch a week. I'm assuming you just don't take a pouch a week and not take it regularly during the week.
Well, I'm a advocate for trying to get small amounts of these healthful things in daily. But actually, because we don't turn over our cells every day, or the life of a cell is about 120 days, depending on the tissue, that it actually looks like if we take large amounts at one time, there is still some health benefit. We still sort of incorporate them into our body.
So it just doesn't wash out.
So it's just get them in your body. Okay, so eliminate white foods, choose whole grains. I'm sure many of you know this message. Question of, is this a whole grain? We have to be really careful. A lot of companies are advertising their products as whole grains now, and I would caution you. Which brings us to the next rule of thumb, which is that real food comes wrapped in husks, hulls, peels, pods, shells, scales, skins, and leaves, not wrappers, cans, bags, boxes, or tubes. Okay, So are you eating a real food? Notice I'm not using the word whole food because I think that that label has really become adulterated, and other organizations and stores and other things are using that term. And I think that the public ends up thinking, well, everything that I buy at this place called Whole Foods must be healthy, and that's absolutely not true. So I'm using the word real food. Real food comes in husks, hulls, peels, pods, shells, scales, skins, and leaves. Like, it grows somewhere, okay? It either eats plant foods and then you eat it, or it is a plant food and you should eat it as a food. Once it becomes manufactured, changed, wrapped in plastic, its nutritional value and the other ingredients that may have other health detriments are going to kind of take over. So here's just some of the amazing whole foods that we have access to. We have access to tremendous food here in the Northwest. And so, the next time you're going out and you're thinking, well, am I going to go to this store, or am I going to go to a farmer's market, or am I going to spend the extra money to get whole foods? I would ask yourself the question, well, who would I rather give my money to? Would I rather give my money to the farmers at the farmer's market who are providing this healthy whole food, who are living with the earth, providing me these ingredients, or would I rather give my food to a supermarket chain or ultimately to a pharmaceutical company? I personally would rather support the farmers. Going to skip avocado. Many of you know about the health benefits of nuts. It really looks like it's a general quality of nuts. It isn't specific to one type of nut. There's a lot of research on almonds. The California Almond Board dumped a lot of money into almonds. For good reason, I actually support that. I think it helps get healthier food and food messages out to people. So almonds are very good, especially for lowering your bad cholesterol, your LDL cholesterol. But similar research has been done on pistachios and walnuts and pecans. There's been research that where they actually have people eat walnuts and then eat a high-fat meal, and eating walnuts with a high-fat meal reduces that inflammatory reaction that we talked about, and it helps the arteries dilate normally. It doesn't restrict that dilation property that we were talking about before.
Is there a difference between cooked nuts and raw nuts?
Yeah, that's a good question, and I think that there would be. This type of study where we're giving people food and looking at what happens, we haven't done that for very many foods yet, and we haven't done it for cooked foods versus uncooked foods in most cases. But because nuts contain those polyunsaturated fats that we were talking about, and because those polyunsaturated fats can become oxidized with cooking, I think that raw nuts are definitely better. However, in this study, they were raw walnuts. In some of the other nut studies, they have been roasted nuts, and we still see some effect. That's probably because the oils on the inside of the nut aren't getting affected by the roasting, and it's just sort of the outside. And the good oils on the inside are still offering a benefit, even though maybe the outer layer has been modified. So I think, again, we come back to the rules of thumb about raw foods, and I think raw nuts are going to be better. But once again, if you have to make the choice of not eating nuts or eating even mildly roasted nuts, then going with the roasted nuts is still going to be a better choice. Now, the roasted salted nut cocktail mix, now you're looking at the roasting process plus the extra oil that's added to the outside of the nuts plus all the extra salt. Yeah, maybe not as good. Question?
Yes, I've heard about blanching almonds to remove the skins because there's something toxic in them, or at least to soak them and drain the water before you eat them. Do you know anything about that?
I think if you have time for that extra step and it feels important to you, then that's good. Almonds and those foods, they're interesting, and they actually contain a little bit of cyanide, and there's questions about whether that's good for you or bad for you. There's some interesting theories about how it might be good for you, because it's actually bound to sugar, and there's some question that, well, if we take in this cyanide that's linked to sugar, maybe it has some impact on cancer cells and things in our body. A lot of that's speculation, but I think it's interesting to think about. I think there's some message that almost any plant, when you take it into your body, it's going to give your body some message, some new information, some effect that is going to change the way that your body interacts with food and with that substance in the future.
What about, like, when you walk in like Trader Joe's or like Whole Foods, they'll have like organic almonds and regular,
Yeah.
and then like a lot of like drugstores sell like those diamond, and most of those aren't organic.
Mm-hmm.
So it's like that's usually where I buy almonds and like chew on and stuff. And like sometimes I get worried. Like I don't know, like they say like organic is so much healthier and it tastes better and stuff, and it really does. But sometimes it's like like if you don't have a lot of money, like
Yeah.
it's easier to buy what's gonna, you know, cost you less, and then like still have that worry, like, oh, you know, like I should have bought the organic. Or
Yeah, it's a good question. I think, you know, what we have to remember is that a lot of the research that's been done on nutritional causes of cardiovascular disease and diabetes and things, and when we look at protective dietary patterns, most of what we know is for people in the general population in the United States who are not eating organic foods. They're not selecting organic nuts. You know, the highest source of antioxidants in the body or in the United States is coffee. And things like things like ketchup and potatoes, including French fries, are still included on the vegetable list. Like they still count as vegetables, in terms of the nutrition epidemiology that we do in the country. And so once again, I think like consuming those, getting in the healthful foods, regardless of whether they're organic. The other thing about nuts is, of course, nuts have shells. And so once you break the shell away, I mean, we know that most non-organic foods that are harmful or that may be harmful, that have higher pesticide levels, et cetera, are the foods that we don't peel or that we don't take the shell away from. So almonds, I mean, each one of those almonds is going to come out of a shell, and I think the contamination is probably going to be higher on the shell rather than the nut itself.
when you buy them, they're never in a shell.
That's right.
So
But when they were sprayed, it was on the shell.
It was in a shell. Okay. So then, you cut it off.
Right,
Cut
well,
off the peel.
I think it comes down to
You
like,
don't eat pineapple peel.
right, you don't eat pineapple peel, and then pineapples also, even though pineapples actually do use a fair amount of pesticides, even though you are cutting it off, but pineapples are grown in an appropriate geographical environment. I mean, pineapples are supposed to grow in those areas. We're not trying to grow them somewhere else. It's when we take foods that are supposed to grow in a different environment and we bring them to a new place, and that's when we need to use lots of pesticides and herbicides and other things in order to kind of make them grow in that area. When they grow there naturally, it takes less pesticides and herbicides, and thus, it's another reason to think about using local foods, eating local foods.
Just over avocado food, basically,
Go back to avocado.
or just mention what you need to watch.
Avocados are actually not on the sort of top 5 or 10 list in terms of best selection of organic foods. Conventional avocados are fine, probably again because you peel them. Avocados, a lot of people shy away from avocados because the fat in them is mostly saturated, but you can also see that they contain a lot of other nutrients besides saturated fat. Lutein and zeaxanthin, these are the carotenes that we were talking about, some of the pigments. Glutathione is that antioxidant that we were talking about. Avocados actually contain glutathione. There's very few foods that contain that antioxidant. Beta-sitosterol is a plant sterol that helps block the absorption of cholesterol from foods that you eat. L-carnitine is an amino acid that helps your body use fat, including the fat that's in avocado. So it's like, wait a minute, you mean this food has not only the fat that I need, it has the amino acids that I need to use the fat, it has the antioxidants that I need to protect my body against the inflammation that can be caused by fat. That sounds like a perfect food to me. And what do you know? It's all in one nice, neat little package.
Thank you.
How many calories is one avocado?
I don't know the answer to that.
Oh, okay.
Yeah, I don't know.
I don't know the calories.
Briefly, this is what happens to your blood sugar if you eat bread and almonds versus bread alone. You can see that bread and almonds is lower. We know that using more herbs and spices in food helps offer anti-inflammatory benefits. Turmeric, for example, reduces the oxidation of lipids. It reduces the reaction to cooked oils. It reduces the reaction to consuming too much alcohol. So again, it looks like it's acting on the liver. We see lower liver enzymes if we feed oxidized oils to people, and we also give them turmeric, and increased antioxidant activity from ingesting turmeric. So we're learning a lot about traditional herbs and spices and how they impact our health. For example, if you marinate a piece of meat in mixed herbs and spices and balsamic vinegar and olive oil and that sort of thing, and before you cook it, then that marination actually helps reduce some of the cancer-causing properties of cooked meats. And so finding ways to bring in herbs and spices is also a good rule of thumb. And here we go. Trying to eliminate sweeteners like high fructose corn syrup. It really is bad stuff. Reduce salt and high-calorie sweeteners such as sugar, cane syrup, agave, and maple syrup. And then really replacing with herbs and spices and natural sweetness. It takes a while to reset our taste buds. That it's absolutely true. That if you go from eating very salty foods, very sweet foods, very fatty foods, and then suddenly you're doing more raw foods and more herbs and things are going to taste a little different for a while, but then you'll find that your palate changes and you actually start to pick up more subtleties in the flavor of foods. And then with some instruction, some cooking classes and using some cookbooks, you'll find that actually combining herbs and spices in the right way really accentuates the natural flavor in foods, and you start to become more used to the sweetness. Salt and sugar just overpowers our taste buds. But genetically, we love those flavors, right? We love them. And so it really takes discipline and practice to try to stay away from them. But once you retrain yourself, you'll actually find that you crave the more natural flavors in food more. We talked about low glycosylation end products. This is just a list of the highest versus the lowest foods. The highest foods and aged products: meat, dairy, butter and mayo, fried, broiled, roasted foods, and then actually fruit relative to vegetables. Not relative to meat, but relative to vegetables. And then lowest are going to be veggies. Fish, unless you fry it and bread it. If you fry fish and bread it and eat it, you're doing more harm than good. It doesn't count. It's no longer healthy. Anything fried is bad. Legumes, whole grains, nuts, boiled, steamed, and poached foods. This took me a while to get used to, I have to admit. I don't only boil and poach and steam foods. But me personally. But actually, I have been experimenting a lot with poached recipes and doing more steaming. You can actually get away with doing more steaming rather than sautéing, especially with vegetable foods. If you just use a little bit of water, and then if you want a little bit of oil, or you add some caramelized onions or something, steam the vegetables first, drain the water, and then add the onions back in and just mix them up. You can get by with a lot less oil rather than cooking all those vegetables in oil. That's right. Yeah, because of fructose. Mm-hmm. Yeah, so fruit is an interesting thing because, is it protective? Is it not protective? It's high in sugar, but it's also high in these vitamins. It's high often in healthful pigments, and yet there's the sugar content. And so, what do we do about fruit? And what fruits do we eat? And I think the answer to that changes depending upon whether you have diabetes, whether you have prediabetes, or whether you don't have diabetes or any metabolic disease at all. I think if you're eating a piece of fruit instead of a piece of bread, or a piece of fruit instead of a donut, or a piece of fruit instead of a big bowl of pasta or something without any activity, then fruit is always going to be the healthier choice. However, if you have diabetes and you're concerned about your blood sugar, you're concerned about your weight, then the situation changes, because then you're concerned more about the total amount of carbohydrates and the relative response that piece of fruit is going to have in your blood sugar compared to, say, a piece of celery or a carrot or some other vegetable food. And so we always have to sort of keep our diet and dietary rules of thumb in the context of our metabolic status and our health goals. And some fruits, like we know that blueberries and cherries and raspberries and our really dark pigmented berries, those fruits contain very little sugar actually, and more of these healthful antioxidant polyphenols that we know protect our blood vessels. So that's usually my recommendation, is to first off focus on the dark pigmented fruits, but then also try to stay seasonal with your fruits. Should we be eating citrus fruits in the Northwest in the middle of winter? Yeah, probably not. And citrus fruits are of course really, really high in sugar. Eat protein with every meal. I said earlier, there's no such thing as essential carbohydrates. There's essential fats and essential proteins. Proteins really do help balance our blood sugar. They give us amino acids that we can make sugar out of if we need to in our body, but they also impact our sugar dramatically. So this is actually looking at whey protein and the relative response to whey protein versus glucose, and we can see that the overall the amplitude of this response is much lower with protein, and the area under this curve is much lower with protein than it is with sugar. Well, whey protein is a natural protein found in dairy products, but it's isolated and then sold as a protein powder. Eat breakfast every day. We know that eating breakfast every day is a significant protective factor against developing diabetes. This is because of our body, we actually wake up in a little bit of a stressful situation. Our body secretes these stress hormones upon waking, including the hormone cortisol. Cortisol's action is to reduce our sensitivity to insulin so that our blood sugar is a little bit higher when we get up. It's so that we can be vigilant and be awake in order to break our fast that we had the night before. And when we break our fast and we get a nice normal insulin response, that actually shuts down our stress hormones and they go to very, very low levels. If you don't eat breakfast in the morning, that morning stress response continues until you eat throughout the day. And so all that period of time, you're actually less sensitive to the hormone insulin. And over time, we think that can cause some significant disruptions in our daily hormonal cycles and our blood sugar. Eat carbs early and eat light late. This is common sense. If you eat carbohydrate foods early in the day, it's easier to burn those calories throughout the day. If you eat them at dinner and you go to bed, guess what? Every piece of it's going to be stored as fat. Okay? Rule of thumb number 10, learn to like vinegar. We're learning a lot about the health benefits of vinegar and the way that it impacts blood sugar. This is, for example, this is bread administered to people versus bread dipped in vinegar, and we can see the same process. It is just vinegar. It doesn't have to be vinegar with the mother, natural apple cider vinegars, although there may be other benefits of the natural apple cider vinegars. But just good old vinegar, acetic acid, has this response where it slows the rate of blood sugar entering our bloodstream. It slows the rate of gastric emptying from our stomach.
I'm sorry. Vinegar, usually when one starts with white vinegar or apple cider vinegar.
Yeah.
Are you talking about apple cider vinegar?
Well, I think apple cider vinegar tastes better. Just regular white vinegar is pretty strong, and
Yeah,
but technically both would work.
White vinegar for cleaning.
Right.
Like natural cleaning or green cleaning. But
Yeah.
if you take it was 2 tablespoons or 2 teaspoons?
It's 2 tablespoons actually, and that was actually specifically a recommendation for people with diabetes.
Oh, okay. Apple cider vinegar?
Yeah, that was one of those studies was done with apple cider.
White, isn't that going to be too strong? Too.
It isn't. It actually isn't too.
Has sort of the fermented apple taste.
Right. Good old white vinegar would actually do the same thing for your blood sugar, and it actually, it isn't unsafe to eat white vinegar. It's a lot of people still mix it in salad dressings and use it in other ways. Vinegar is an acid. It's acetic acid, and white vinegar is just acetic acid. It's almost as pure as it can be. Apple cider vinegar, you're getting some of the more natural fermentation byproducts, and some of the organisms are still in there if it hasn't been filtered. So if it's just unfiltered raw apple cider vinegar, I find the taste is a little bit better, and there's probably some health benefits from those organisms. So it's my preference too. But white vinegar actually does work. Yes, ma'am.
What about delicious balsamic?
Yeah, I think balsamic vinegar is great. I really salad dressings used as marinades. Dipped in whole grain breads if you're going to have bread. All of those uses. There's a white balsamic vinegar, which was new to me. I think it has a very delicious flavor. So, again, there's all these different ways that we can think about food, and if I had to recommend one dietary pattern, then it is the traditional Mediterranean dietary pattern. You'll notice that at the foundation of this dietary pattern, or this dietary pyramid, is to be physically active and to enjoy meals with children and to be sort of socially engaged. There was a study that was done by another investigator at Bastyr recently that looked at the role of eating behaviors and how it impacted blood sugar in people with diabetes. And she actually found stronger correlations to changes in eating behaviors with A1c changes and blood sugar changes more than the changes of, say, fewer carbohydrates or more vegetables. It's the behavioral components of how we eat that also have an impact on the overall nutrition. Notice that the foundation of the food part of the pyramid here is mostly fresh vegetable foods, some fruits, some grain products. Followed by proteins. This is showing our marine-based proteins because they have so many polyunsaturated fats in them, these good healthful oils. followed then by animal proteins. Notice poultry, we don't see a big steak here. Poultry and lean meats. Red meat is not only high in saturated fat and cholesterol, but it's also very, very high in iron. If you need iron in your body, that's fine. Women tend to need more iron than men. But iron rusts. Iron promotes oxidation, and this happens in our body. We know that increased iron intake and having iron overload increases risk for vascular disease and increases risk for liver disease as well. So if you are what you eat, so which would you rather be? Pretty standard. And that's the food. Exercise, of course, is another important point. I'm not going to be able to talk about much detail. Exercise is your reward. Reframing exercise is a time to get away from everything else, to concentrate on yourself, get some time and space, to move your breath. Finding enjoyable activities to do. Very few people enjoy walking on a treadmill. Okay, it's not particularly engaging. I have people now are telling me that there are these interactive kind of video displays with bicycling in the gym as well as treadmills where you get to pick your setting and you can run along the coastline. Well, guess what? We live really close to the coastline. Just a reminder. All movement counts. Okay, standing versus sitting increases your metabolic rate by almost 10%. Standing and fidgeting versus just standing still increases your metabolic rate by 90%. Move, move, move. Got to move your body. Aerobic exercise is good. It's best when it's combined with resistance exercise. So this is strength training exercise, actually moving some weights around. Strength training exercise builds lean muscle. Lean muscle is very insulin sensitive tissue. It really responds well to glucose. So building strength, making your body hungry. Remember we talked about how little energy you spend flipping through the channels or going to get your mail? You have to make the tissue hungry. And then eat. Chronic stress is a route to diabetes. We know that stress hormones reduce our sensitivity to insulin. It's pro-inflammatory. It actually, if we're under stress, our liver makes more sugar. Our liver is able to make sugar. We talked about that. Can make sugar out of protein. If you're under stress, your liver keeps cranking out sugar, whether you need it or not. If you just ate a whole lot of carbohydrates and your sugar's high and you're under stress, guess what? You're going to make more, and your blood sugar is going to go even higher. And so all of these things can lead to diabetes, and we see evidence of that in research. People who had really, really high stress scores had twice the risk of having prediabetes and over 3 times the risk of having diabetes. I'm not really going to say anything about supplements, other than I will say one statement about supplements. We do not have any clinical research evidence that any supplements prevent type 2 diabetes. Okay? Supplements have their role. They can offset nutritional deficiencies. They can be used to reduce symptoms. We do have evidence about them improving and changing all kinds of things related to cardiovascular health and blood sugar health. But we do not have a single clinical trial that shows that a nutritional supplement prevents diabetes. And so this is an area to be very, very cautious, because this is really the why not around supplements. It's because it's tempting to supplement or to take any sort of pill in exchange for making lasting changes in the way that you live your life. Okay? If you go to see the other guy is very likely to write you a prescription and then write you another 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 prescription, and you just keep living your life exactly the same way. You don't have to do anything differently. Well, I disagree with that. Okay? I think that there are things that people can do differently. There is responsibility that we can take for our own health and the health of our communities. And hopefully you learned a few of those things here today. Testing, one thing I'll say very quickly about testing, because I know I'm way over time. If you haven't been tested, if you're over age 35, if you have any of the risk factors that we've talked about, it is important that you see a physician and get tested. We do screen your hemoglobin A1c as a screening test for diabetes. Again, 50% of people out there who have prediabetes and diabetes don't know that they have the disease. So if you haven't been screened, you should be screened.
When you get regular blood tests for your annual physical, is any of that indicative of pre-diabetes?
Yes, it should be. It should be. If your primary care provider does a preventive screening lab, chances are that would at least include a fasting blood sugar, and a fasting blood sugar is another screening test that we can use for diabetes. The current recommendation is to use a hemoglobin A1c because, again, we pick up that blood sugar after your meals as well as that fasting blood sugar piece, but a fasting test is a good test.
So you need to request.
You would probably need to request, and then of course I'm surprised by a lot of patients come in and they say, well, my doctor told me I may have a little bit of diabetes. Well, guess what? There's no such thing. You know, it's diabetes, yes or no. Mild, there's no such thing as a little, there's no such thing as early. Okay. I think that all of those labels are actually a bit of a disservice to people because it sort of undermines the severity of what's really going on.
It doesn't stop you then to make changes. It lets you go on another 5 years having a little bit of diabetes if they let you go.
Sometimes. I am way out of time, so I'm going to skip through all the liver stuff. Hopefully I can do another talk and you guys can come and hear about the role of the liver and how it impacts this and those factors. One thing I will bring to your attention is we have a study going on at Bastyr where we're trying to learn about the role of vitamin D and how vitamin D impacts risk factors for cardiovascular disease and diabetes. With this study, we actually test your vitamin D level, and which we pay for. And if it turns out that you are deficient, then we actually will even pay for you to be supplemented for 12 weeks, and then we pay for your retest 12 weeks later. So there are some participation criteria. I'm not pushing you, but if you're interested in being screened, if you don't know your status and interested in maybe participating in the study is only 12 weeks long, and then we also pay you $50 to participate. There are some flyers in the back that have little tabs with the telephone number. So if you have any interest, please sign up. And thank you all very much for your time. Sorry I went over. Thank you for staying, and enjoy your son. Thank you.